Okay, good afternoon, ladies and gents. I think it's already now a minute past, so let's officially open this curiosity. I'm Javier Klopper from the Vinci Institute. I'm the Executive Dean, Research and Institutional Partnerships. For those attending the first time, if you will allow me to quickly introduce the Vinci Institute of Technology to you in a few minutes, and then also a quick overview of what Curiosity is all about. So at Vinci, our dream is to influence the co-creation of sustainable societies. And we really live to that dream. To make that happen, our purpose, we believe, is to grow agile, aligned, and engaged managerial leaders. And coincidentally and quite appropriate this afternoon, we are talking about leaders and leadership and how we need to think about that in the space of leadership and also in the medical fraternity. Our brand promise is to co-create realities. And we firmly believe on the co-create, collaborate, and cooperate. Our strategic intent at Vinci as a distance training institution is to strengthen the growth of agile, aligned, and engaged managerial leaders who co-create innovative ecosystems and sustainable transformational societies. And I think that's really the core of what we do. Then behind all of this, we have 8 core principles. And you can read more about them on our website. The very first one is that of being curious. And that's also why we are having this session once a month, normally the second last Tuesday, called Curiosity, where we sit around the table and we talk to each other about interesting and relevant topics. So as I said, it's a monthly colloquium for contemporary thinking on management of technology, innovation, people in a systemic context, and we refer to that for those people that know Vinci very well as the CHIPS managerial framework. The forum takes the form of a robust and a vibrant roundtable discussion that consists of 2 parts. First, we have a doctoral student that will share with us his or her current journey, where he or she stands, and this afternoon it's a privilege and honor to welcome Mr. Mark Eccles, which I'll introduce to you in a few minutes from now. And then the second part, we have an industry leader speaker with a societal influencer that can engage with us on a specific topic. And for that, I will also introduce you to Dr. Andy Broth a little later here this afternoon. The purpose of Curiosity is to stimulate debate, provoke thinking and connect people, get around and to probe and reflect on issues that influence society. So for those that are familiar with that, it's not a presentation format. I will pose a few questions to Mark and Andy and also to the audience. And as audience members, you are more than welcome to pose questions or make a comment as well. It's all about interactivity and we would like to engage with each other. Before we get into the 2 sessions, we also thought it good to as an icebreaker, reflect on a current thing that happened in the press or current thing that attracts a lot of attention. And I think if we look at what's the discussion last week or 2 prominent in the political arena, in the mining industry, I don't want to say in the sport, but in the cricket South Africa environment, it's all around the accountability of leaders. And as we move into the 5th industrial revolution, the question we can ask ourselves is, how do we need to think about leadership, about the accountability? Is it not a construct we misunderstood? And I think it's clear from looking at all these discussions that the future of world will be a world of connections and connectedness. It will be about connecting people in ways that allow them to work at a higher level, become much more productive. It will be about connecting businesses across the ecosystems. Hence the topic of the next Curiosity are also very relevant, so that they can implement digital business models to effectively and competitively operate in the markets. And it will be about creating connections across technological platforms so that traditional monolithic experiences are replaced with modern ones. And I think in that conversation, for us, it's important to always engage with each other. So as a first question to anybody in the audience or as a remark, what I struggle with and a question I often ask myself, how will the new world of work look? At the moment, I'm reading a book by Daniel Susskind, and it's all about a world without work. And I think by reading that book, one starts to reflect about this and say, as productivity increases, some jobs will become redundant. It will be replaced. It's clear that we move from agricultural sector into manufacturing environment, and nowadays it's a service environment. And if you pick up the discussion, the investment sector in the last few days is moving into a few high-tech businesses. So anybody in the audience that would love to respond and have a specific view on how the new world of work will look, any characteristics that we can share with each other, and as we then continue this afternoon, we can also ask the two speakers to reflect on that. Maybe my own thoughts. If I look at the new world of work, I think it will be probably 3 characteristics, if I can say. The first one, it will be a digital experience. It will consist of digital networks. And thirdly, it will be digital journey. Now, in that space, I think as human beings, true to the approach in the 5th industrial revolution, we must be careful that we don't become products of technology, but really use technology to our advantage to become more productive, almost see technology as enabler. And with that, things like artificial intelligence, automation is actually not a threat, but it's a tool at our disposal. And I think we need to ask ourselves, how must we think about that? What must we do? How would it change our business? How will that inform our decision making? And I think that's really what we want to stay core to. I see there's a question from Tia Pelsi. In my view, the new world of work will be one that is integrated, without any doubt, the integratedness. If you just look at how easy it is for all of us here this afternoon to participate in this forum from all across. Very true. Thank you for that remark, Tia. And we need to bring that in our personal lives. And if I look at the discussion amongst medical doctors and psychologists, more and more increasingly they are worried about the psychological health and not so much the physical health of people in this post-COVID. So the last curiosity we had, we ask ourselves, what are the economic realities pre and post-COVID? And I think that's a conversation that will definitely will be continuing. I also have another thought, and that's sharing knowledge and timelines on strategic developments and explaining the significance of these amongst our fellows and colleagues are also important, because at the end we must take people with us, we must mobilize that, and we must allow input from all angles. And I think with that being said, it's probably more and more important that leaders, but also all employees become accountable. And that's something we need to think of. I see there's another remark here. The onus to learn and to be productive will be the responsibility of the individual and less than that of the facilitator. Tia, I fully agree with that one. I think, long past are the days where the facilitator or the person who knows everything, he or she just become a co-creator. Where I'm sitting, people talk about pedagogy, andragogy, and hortagogy, and I specifically subscribe to the latter part, where we take responsibility for our own learning and almost become a self-centered learning environment. And I think that's the beauty. We can decide what we want to do, what we want to read, but as long as we learn, so we can, in essence, determine our output. And hopefully in the future, we'll move to what we refer to as micro-qualifications, little building blocks, skills-based. I think that's definitely where things are going. Just looking at the last comment, Janet also say, I think someone there will be an increased level of protectionism with many faces, for sure. I think Andy will probably touch on it a bit later, and I think even Mark will do in his presentation. As human beings, we categorize our decisions, and being trying to put things in boxes, we almost fall into a compliance mode. And as we protect, we actually neglect to create an open system, which is very important for debate. Maybe I'll take one more remark. There's one from Heather. The new world of work will be reward interpersonal skills, collaboration, good communication, and creative thinking. Heather, fully agree with you on that one. And that's something that I think we will definitely touch on this afternoon as well. So maybe a question that I leave you with and a challenge, and we can follow the discussion on that. How can we be more accountable? How can we be more responsible? And not just for our own sake, not just for today, not just for tomorrow, but also to leave a legacy, an opportunity behind for generations to follow. And I think, that's really a an important aspect that we need to focus on. It's a privilege for me to introduce Mr. Mark Eccles this afternoon, who will share with us some of his thoughts underpinning his doctoral study, the Doctor of Management, Technology and Innovation at Vinci. The title of his thesis, and that's under supervision of Professor Paul Singh, that's also present with us here this afternoon. The title of the study, Towards a Regulatory Framework to Promote Value-Based Healthcare Outcome in South Africa. And I think if we've been following the healthcare system, it's definitely a relevant topic, and I think Mark is onto something big here. Background on Mark. Mark is currently a practicing attorney who focus on corporate and commercial law with clients in the financial services industry, ICT, general industry and professional service. He holds a BCom and LLB from University of Witwatersrand, an LLM focusing on company law and competition law from UNISA, and also a higher diploma in tax law from the University of Johannesburg. Mark has worked as an in-house legal advisor and in private practice. He's also seen as a co-founder of a venture capital management company and tech fund, and is still involved in fund management as a qualified key individual under the FACE Act. For personal and professional reasons, the healthcare sector industry has attracted his attention. Hence, he's decided to pursue his doctorate on that, one that is most need of urgent attention, and as Mark clearly stated, reformation, and that will be the focus of his doctoral thesis. As a fundamental principle, Mark believes that productive laws and regulations should create competitive markets, which in turn enable the development of improved products and services at reduced pricing. That equates to better quality of life for those living in that economy. A lot of work has been undertaken to study the international healthcare system as a basis to his doctoral thesis in the last decade or two, with a focus on value-based medicine. As we will follow a roundtable discussion this afternoon, I will pose a few questions to both Mark and members of the audience. Please feel free to either leave a comment or ask a question in the chat function, which I will also monitor carefully as we proceed. So without further ado, if I can then ask Mark Eccles to join us. Good afternoon, welcome here, Mr. Mark Eccles. We're really privileged to have you here talking about your doctoral student. To start off, how can you summarize your study, maybe in 5 sentences to the audience member, just to open up the conversation?
My general view on life is that a picture speaks 1,000 words. So the study seeks to analyze the current South African healthcare system, but from a legal and rules-based perspective, and to identify the manner in which the current system is structured. So if you look on the left-hand side of the screen, you'll see that it begins with, it's almost in 2 parts. The sort of gray boxes are the first part, and the blue, I hope it's blue, I'm a bit colorblind, on the right are the interview process is the second part. So the first part really is a documentary analysis, and the first being a doctrinal analysis of the South African healthcare legislation, and looking at it from a systems perspective, and looking for the rules and regulations that form that system, and therefore, I believe, give us a certain outcomes. Then the study looks at the review from a systems perspective, again, of the phenomenon called value-based healthcare, and looking to find out what rules and or laws would underpin such a system, and whether or not these could be incorporated into a South African healthcare framework, whether it would involve adjustments or maybe even a fundamental overhaul of the South African regulatory system in order to achieve better outcomes. That's sort of phase 1. Phase 2 then is to take the outcomes of that inquiry, of that analysis, and to put them to industry stakeholders, through questionnaires, and probably looking at focus groups, multidisciplinary focus groups, so that one gets a holistic response. The idea really being to say, if one could provide a fresh or a new perspective on healthcare and healthcare delivery, whether it could create a more positive conversation around these very, very important issues. If we may or may not know, there is a little bit of a standoff between public and private sector, between providers and funders, and accordingly, this seeks to to unpack the issues and see whether or not there is I hate to use the term, a middle way, some way in which one could break some of the impasse using systems theory, but also using rules and law as a system. Perhaps I can go one step further, and I'm sure it was one of the questions that would be asked, and we can unpack it slightly as well. The controlling idea for me behind the study is that good laws create good markets. Good markets then create an environment in which products and services are created and delivered with improving quality, reducing cost, and that they become more available. And in the healthcare environments, they talk about the iron triangle, and that is quality, cost, and access. And one wants to use the rules of the game to accomplish this.
Thank you for that, Mark. I think what I really appreciate about your diagram is that you apply various lenses to that, something that sort of Vinci and I and me and my colleagues are very comfortable of, to say, how do we lens and view things differently? What I also appreciate in there, and I think I want to underline it if I listen or followed you correctly, is similar to our TIPS managerial framework. The way you've provided the diagram, it actually put you middle square in a transdisciplinary perspective, which is good because it's not just a silo approach to that. And I think if I listened to you correctly, you say there's a phase 1, phase 2, and it will actually unpack that. So a question that I have on my mind, and please, if there's something for somebody else, please pop in, is with that being said, and I see that, what's the big ideas, in short and sweet, that binds your study in your thesis together?
I think the central idea is that healthcare delivery is a system, and that one needs to apply a systems perspective to it. And so this ties in with my legal bent and my belief that every system has a set of rules, and the rules can be explicit or implicit, and they will determine your outcomes. So, for example, in the healthcare environment, an explicit rule would be that all healthcare practitioners need to be licensed. They need to be qualified and licensed and regulated. That's explicit. But an implicit rule of the game is that we remunerate our healthcare providers in the private sector on a fee-for-service basis. The outcome of that particular rule, if I can call it that, is that if you want to increase revenue, you just increase volume of service, which then leads to phenomena like over-servicing, or sometimes what they refer to as supply-created demand. So it's not a written rule, but it's a rule of the system that comes about as a consequence of just a phenomenon in the system. So rules can be explicit or implicit. The manner in which they operate then creates certain outcomes, and the outcomes themselves can be satisfactory or unsatisfactory. I think in the South African context, because we essentially have two systems of healthcare, public and private, we have actually got a broken system to begin with. One needs to then consider what a unitary healthcare system would look like in a South African environment. And so I'm looking at it from a rules perspective. So what rules govern the South African healthcare system as it currently exists? Then deep dive into the concept of value-based healthcare, which looks then at better quality, reducing costs, and increasing access. In some of the literature, they refer to the healthcare system cube, and they talk about length, depth, and breadth. And so then you've got to ask yourself, is there a preferable set of rules? If a good system needs good rules, what would these rules look like? And then try and marry the two together. What we have in South Africa currently, and what would perhaps be an ideal set of set of rules to make such a system, and then look for the gap. It might be a gap that needs to be closed. It might be a total reconfiguration. But I think the main idea is a systems and rules approach, which ties back to the law creating the system that gives us the results or not. The other controlling idea probably is a human rights perspective. And obviously in the South African context, we have to start with the Constitution. And so the presuppositions of the Constitution being human dignity, equality, and freedom need to underpin. So the literature around systems tells us that all systems have embedded values. And so no system is values free. So probably the next major idea linked to my study, besides the systems and rules approach to creating of a marketplace, and I use marketplace in inverted commas, that's a debatable point when it comes to healthcare, is to infuse that inquiry with a human rights perspective, with everything that entails, from social solidarity to freedoms of choice. One of the elements that I preoccupy myself with is that the freedom of healthcare practitioners to practice healthcare is as much as a right as a producer as the rights of a consumer of healthcare products and services. And so the system needs to balance all players.
Thank you, Mark. I think that was it's a mouthful, but I understand it better after you explained that to me. I see there's a question from Dr. Andy Broth. Andy's asking, Mark, do you have a view on the viability of the proposed universal health coverage in South Africa from an access, quality, and cost perspective?
So yeah, I mean, one of the interesting things of the study, and I've been enrolled now for 4 months, has been to look at how we've got to where we are and looking at the conversation. And of course, when you start looking at something like NHI, it's a very important additional part of the conversation, and it poses certain very critical questions. However, I along with others, take the view, actually, funnily enough, I was looking for something else today, and I came across a synopsis or summary of a critique of for example, the National Health Insurance proposal. It says it is a funding mechanism masquerading as a health delivery system. And so when one looks at both those for and against the NHI, who critically look at it, recognize that we are not adopting a holistic perspective. We are staying within our silos of public and private, and we are trying to advance the an absolutely necessary coverage issue that is confronted by the public sector by trying to co-opt the funding across the board and to put it into place. So in my study, we definitely will be looking at the dynamics associated with that. But there's a lot of literature that points out that in healthcare provision worldwide, the concern is often about how do we fund healthcare. But the funding and the cost element is only one portion of it. I mentioned the so-called iron triangle. The other is quality, and then access. Access to low quality healthcare is not healthcare provision. So we have to focus on value. And that's then where the focus of the study is, about unpacking this concept of value-based healthcare, which says that one needs to look at value for money. You need to work out how do you measure and reward performance in the healthcare system so that you get better quality at, over time, reducing value. So someone like Diane McIntyre, who's been in public health and in health economics for 30 years, I think, at UCT, she, in her most recent articles, is counseling against the use of universal health coverage and saying, let's focus on universal health system, bringing in the systems thinking, which means then we can't give coverage of everything to everyone now, but we need to create a system that over time will increase the depth and the breadth and the width of access. So we must begin, I think, with universal access. All the population needs to be covered by our healthcare system. Then you have to begin to work on how deep is that access? It begins, I think, with primary healthcare, and then you've got to deepen and deepen the access. And we know that if you combine a public, maybe I should use the term public, let's say a social solidarity perspective with private sector initiative, which is properly regulated and properly rewarded, moving from, say, for example, from fee for service to fee for performance is one mechanism within value-based healthcare. And look at how do you create a place where there is innovation and the marketplace, the professionals in the marketplace, together with, I believe there needs to be a greater integration between, let's say, business and innovation and science and medicine in order to achieve a progressive increase in the quality and scope of healthcare. But you do have to start with, I think, acknowledging there has to be universal access, and then working to deepen that access, beginning with primary healthcare and working your way through. And I don't think it's a particularly good idea to confine primary healthcare to public and secondary and tertiary healthcare to private. I think there's scope for, in fact, I think for innovation and flexibility, you have to integrate the systems. I'm getting slightly ahead perhaps of a question, but for me, this is one of the difficult areas of the study, is being explicit about my own socio-economic paradigms and philosophies, and realizing that within healthcare, I mean, you've got free market, laissez-faire on the one hand, and then you've got social medicine on the other hand. And I think South Africa is uniquely poised through actually the balance within our constitution to try and marry and come up with a marketplace where there is a public and private sector dynamic, where the state plays a developmental role, but in so doing develops human resources and businesses within the healthcare sector, whether it be practitioners, devices, pharmaceuticals, etc. It's a very complex environment. So you actually need to develop a market that's able to mature and produce over time the types of results that you want to get. I hope that answers the question.
No, I definitely, Mark. I think it for me reflects on the main issues and debates in the subject area. And I think to your point, and I was looking at Janet Dupree also provided us a comment there, say, hi Mark, I'm sure that you would agree that quality does not have to be expensive. I think that's the important point you're making, and this appropriate access is a huge consideration. What practitioner mindset might need to be changed for this to work? I think that's a good question, Janet. Now, Mark, you must answer that question for us as the expert. What the practitioner mindsets might need to change for this to work, to make sure that the access is there for everybody.
Yeah, it's a critical question, and in fact, when one goes into the literature on the value-based healthcare, and particularly certain movements and organizations worldwide, the education of the medical practitioner to take into account in a constructive fashion the costs of what they're doing versus the benefits. So in markets that are more transparent, and that doesn't mean to say they're good. So for example, if you take the US market is actually very similar to ours, and the numbers in terms of waste in the private healthcare system in the US and even in South Africa are huge. So in some of the literature, they refer to the paradox of wasteful excesses and deprivation, or at the same time. Some people are getting far too much, whether they need it or not. Some people are being overly medicated, overly serviced. And then, of course, there are those that don't get serviced at all. And so in the past, and I think this is also the way the South African system has been created, you've got the profession, the healthcare profession, and their job is to is to practice medicine. Almost they prefer to disregard and make the question of cost and who's going to pay someone else's problem. And so we've almost ended up with a unhealthy split again between the practitioner and the funder. Currently, we've got a battle of jurisdiction. So now we've got various of the medical aids, and particularly the medical aid managers, sort of at loggerheads with the profession, and their claim will be that the profession are over-servicing, overcharging, they're greedy on the one hand, and those in practice will say, you're trying to tell us how to do medicine. We are the professionals. You don't have any ethical obligation to the customer, the patient at all. That's our job. There is any systems improvement needs to break down some of that conflict and look at how one integrates those decision-making processes. One way of pushing it that way involves bringing more business innovation. I'll use that term very broadly, not just process innovation in how you deliver your healthcare, but also looking at, a friend of mine just completed his PhD looking at the costing of various procedures worldwide, even within one country and sometimes within even one hospital group. On a standard operation like appendectomy or for appendicitis, etc., you can have 20, 30, 40% difference in the cost of that item. And so one needs to begin to integrate, I suppose, some of the other disciplines into medicine. So business process engineering, accounting for activity-based costing needs to come into it. Because at the moment, one of the problems you've got, and unfortunately, because the doctors are almost precluded from participating often in the business of a hospital or in other elements, they're in their silo, they just have to pass the bills across. And the only people at this stage that look at trying to put it together are the funders, but they too have their own agenda. So there's definitely a need to bring a systematic or systems approach to how does a practitioner make decisions based on the cost. And do they even know what the cost is? They've put their bill into the system. They don't know what the hospital's charged. They don't know what the other specialist is charged. And at the end of the day, it's the medical aid who've got their limits. And then very often the private system, the patient sits with an out-of-pocket expense, which can be crippling at the end of the day. And so the cost conversation needs to come in. I believe it's got to change the mindsets of all the players. But I agree with Janet that the mindset of a practitioner needs to incorporate considerations of cost and, I suppose in some ways, relevance or even cost benefit for the client or patient. Of course, the difficulty is how do you make such calls? And of course, this comes down to informed consent from a patient, is how do you decide whether they will get a better quality of life from spending the extra rand or extra 10,000 rand versus them not doing it. One of the difficulties coming in and talking about mindsets change, something one has to deal with is the whole idea of medical legal, so the so-called malpractice. From my perspective, and there's some interesting precedents worldwide that I think, again, one needs to take a systems approach to. The sort of free-for-all medical malpractice regime in places like the US, I don't think are systematically, from a systems perspective, to be encouraged. One's got to come up with another mechanism for dealing with medical malpractice and dealing with shortfalls in performance. The only, and I'm a lawyer, so I can say this, the only beneficiaries, the main beneficiaries from a litigious scenario are the lawyers. And that is one of the largest, in the private sector, one of the largest increases of cost. And in the South African context, actually one of the larger burdens on the public healthcare system, which at last count, I think, had over between 2 and 3 billion rands worth of outstanding claims for malpractice in the public sector. So I've pushed it a bit further, but mindset changes across the board are required. But some of those will only be possible if the legal parameters or the manner in which we organize our system are changed in order to try and put everyone on the same track, which is universal access to quality healthcare, the access of which grows over time because the cost comes down, and costs only come down through innovation. I think, again, one needs to allow for a layered healthcare system where, yes, those with the most resources will pay and get the best quality healthcare. But if it's done properly, they will always pay the way for the innovation that allows the costs to drop, and you're meant to get a closing in the middle. And that's a whole other conversation around the role of competition in healthcare, which is a vexed issue, but a necessary issue.
Yeah. Now, Mark, thank you for that. I think it's a very important reflection that you provided with us. And if I hear you correctly, you say the challenge is to create a healthcare system that is universal, and therefore it's a human imperative. And I think that's the point you're making, and you drive that down very strong. And by looking at it's a comment from Janet as well. It's a bit earlier, say, talking of waste, a lot of work has been done by lean practitioners in healthcare, especially within the USA context. And, that's something to note, and we must keep that in mind, not to go down, make the same mistakes. And then the last thing, she say love, and that's in capital letters, what Mark is inferring about the need to really effective systemic organizational development. And I think that's an important point. Now what you've said, Janet, I'm actually curious, and Mark, I'm not sure what your opinion on this would be, but with the lean practitioners and, the systemic organizational development, my question to you is what do you think are the most recent major developments in your area that we must take note of as an audience? Because we all have our medical schemes and we worry about that, but what are the main issues, if you can filter them for us, please? And maybe this is a difficult question, but I would really love to know.
No, it is difficult. I think I've touched on some of them. So in the South African context, I'll use as the main example, but it's actually the same worldwide. So the big issue really is the cost and quality. So in a system like South Africa, you've got this untenable, unsustainable, and unjust scenario where you've got the private medical system catering for 17% of the population, and then the public system, which is underfunded, broken, dealing with the other 87%. And then the amount of resources allocated to each of those two buckets is approximately the same. So you've got private healthcare servicing 17% of the population, using as much resource as the public sector. Peculiar enough, that's the one that everyone focuses on, but there's another bucket to the side, which is people don't necessarily pay too much attention to, although it came out in the Competition Commission inquiry into the private healthcare market. Almost as much is spent by you and I on out of pocket. So it's not in medical aid or top-ups, and it's not public, it's pay for service at point of care. And that's almost as much as the other two, which demonstrates that you and I are, and as a middle-class South African, you are paying your taxes, you are paying your medical aid. Taxes are high, medical aid is high, and then you are still, at some stage, when you really need it, you're going to pay out of pocket. You're going to top up somewhere. And so something we need to consider, and there's quite a lot of the conversations, particularly out of the public health fraternity, are around the fact that we need to have a conversation that says, as South Africans, we need to start thinking about our healthcare system holistically. So for you and I, and for the majority of us, I think on this call, we are going to have to get into our minds that, what, we probably would be better off if we pooled the resource and looked at risk sharing across the board. and not have to nitpick and try and work out which system or which medical aid package is going to cover you. Because one of the problems with medical is you and I don't know what we'll need tomorrow. And that's part of the iniquity of the private funding mechanism. It's a bit of a lottery. And so I think we are going to have to start as individuals understanding that we're going to have to be part of a unified system. And I think we should then look at what our medical aids should be doing for us. I think then that we are not going to avoid some form of risk pooling and single payer. But for me, that does not necessarily mean that healthcare then becomes public totally. Ideally, and I said some of this is idealistic and something I'll have to bear in mind when I do the study is, on the one hand, I am for progressive taxation and risk pooling on the funding side. But then I tend to then want to go towards private sector, innovative healthcare supply and service. I think the state should be a good regulator and should be funding the shortfalls in the marketplace, which really are funding shortfalls. For those that cannot afford care, there should be a bare minimum and growing coverage. But that doesn't mean to say, so maybe the state should be focusing on that. So this is the sort of political and or policy issue that you and I as citizens need to consider is, what is the role of the state? I think there is a role for the state, but perhaps it's on the funding and regulatory side and measurement side and research side, and not on service provision, and that we should allow the medical fraternity to reorganize itself and be able to offer different packages of healthcare. One of the big trends is towards bundled costs and the idea of a cycle of care. So instead of if you and I get sick now, badly sick, your GP will send you to a physician, and you'll end up seeing 3 or 4 independent physicians. You'll be in hospital and you end up with a composite bill, and none of the individuals know what the others are charging. And if you had no healthcare, you actually got no idea when you come in the system what the bill's going to be, anywhere near what the bill will be time you get there. You hope that your medical aid is keeping an eye on it. There is a trend towards, particularly, there are many different maladies and morbidities, but there are very clear risks through one's lifetime. And the question then is, can't the practitioners who know their stuff come up with what they call bundled payments? And then they must manage the risk and provide you with the best quality for the price they charge. And then the question is how do you measure for performance, and how do you price and pay for performance? So that's one of the main things that we need to be aware of. The pressure for universal coverage, universal health system is here to stay. But then the focus shouldn't be on just looking at the funding. If we don't fix healthcare delivery, we'll just pour good money after bad. And there's a lot of literature that tells us that the quality, although potentially the quality in the private sector is good, the actual experience in the private sector is not as good as we'd like to think. I don't know about you, but I heard quite recently from someone who is a counselor, and her comment to me was she couldn't believe how many cases she had in counseling of people who themselves or their relatives during this COVID period had gone into had private procedures done that were not successful and had to be redone at substantial cost and pain and suffering. And it just reminded me that the private system is not perfect either, and that it is organized in a manner which doesn't provide us, I think, with value for money. The health market inquiry by the Competition Commission pointed out that there's definitely an over-concentration in the private funding and private service delivery, and we should support any initiative that allows for a greater choice and access to quality healthcare. Yes, so you need to have practitioners who are responsible and can be disbarred. I'm using a legal term. I can't think of the medical term for that now, but taken off the register if they commit malpractice. But we shouldn't be trying to regulate how many people are in practice, how they practice. Those decisions should be left to others.
No, No, Mark, that really makes good sense. I think that's extremely valuable advice that you gave to us. And then I think you've also shared with us your main concerns in this area. I see there's two reflections, comments from Janet. You say innovative design is emerging as a critical pillar in the mitigation of wicked problems, and bundled care so valid for chronic conditions. And I think that's an extension to what you've just said. Better outcome and better value possibilities is available there. And then TLP also say one of the reasons I've heard why private medical costs are so high is due to the high insurance costs.
Yes. Again, it's a systems problem. I think it's true. So, for example, and there's a very good example, and it cuts across public and private. It's in obstetrics and gynecology. It's become a cottage industry now to sue if there are complications during a birth. And the current scenario is that it's almost impossible to practice as in obstetrics and gynecology because of, as an individual practitioner in particular, because of the high claims risk and therefore the costs of your insurance. So clearly, I mean, it's an absolutely critical service. It's a stage of life health issue, and the system is creating a problem for itself. So it is true, it creates great costs. But the other element too is that this is the most peculiar thing. In the South African context, in many contexts, we've said there's not enough supply of doctors and healthcare practitioners, and yet we have kept the number. I think we've increased the number of educational facilities for doctors. It's only increased by 1 in 25 years. How? That's why we have to, inverted commas, go overseas and recruit people from Cuba, etc. Where I think we've got 8 medical schools. Cuba's got over 100 medical schools. So they actually export people, which I don't agree with. But it's a phenomenon. And so the question we have to ask ourselves is, are there not constraints within our system that pushes up the costs? And by reducing the number of practitioners, you create a monopoly, and you can charge what you want. And now we have this problem with people not wanting to be public service, being in private service, because that's where the money is. So these things are all, to round it off, are all symptoms, I think, of a system that is dysfunctional. And in the study, it sounds like being quite ambitious. In the study, I'm hoping to synthesize some of these principles down to some core rules to say if we had to reorganize ourselves in the following fashion, and for that we would need the following regulatory framework, I think we could have a more healthy healthcare system.
Janet, make the point, we need to educate people differently, and to also say we don't just need it for South Africa, but other countries also. And I think going back to your diagram, we started off, to your point, it's a system thinking and it's a holistic approach. So we wish you well on this study. Definitely a mouthful, but it will be interesting to follow your study, and closer to the end of the study, we will arrange a defense of your study, and we will get more insights at that point in time. But being part here for the first part of the afternoon, we really appreciate your thoughts, your wisdom and input here. And for that, we thank you.
Yeah, thank you very much. It was a great opportunity.